have another questions. I have a lot. If there is a test that we can do to say where am I or when I'll be menopause or if I'm menopause, and I'm like, no, there's no such test. If someone want to tell you that, it's not existing. When it is, I'll be happy.
Welcome to This is Perimenopause, the podcast where we delve into the transformative journey of perimenopause and beyond. I'm one of your hosts, Mikkel.
And I'm your other host, Michelle. And together, along with about 1 billion other people on this planet, we're embarking on this milestone of life. We personally struggled for years with perimenopause symptoms, and it took us a while to figure out what was happening. Even now, there are some days that are still a struggle. We know firsthand how confusing, overwhelming, and downright scary this phase of life can be.
So we're on a mission to help others be better informed than we were when we started our journeys. Our podcast is a blend of health, education, mindset, and personal growth. We're sharing real-life stories and expert advice to help you navigate this journey and advocate for your best health.
Because this stage in our life is an incredible opportunity. We used to think menopause signaled an end, but really, it's just the beginning.
This podcast is for general information only. It's designed to educate, inspire, and support you on your personal journey through perimenopause. The information and opinions on this podcast are not intended to be a substitution for primary care, diagnosis, or treatment. The information on this podcast does not replace professional healthcare advice. The use of the information discussed is at the sole discretion of the listener. If you are suffering from symptoms or have questions, please consult a qualified healthcare practitioner. Hey, Michelle, how are you?
I'm good. How are you doing?
I'm good. You had a good weekend?
I did. It was super fun, but I'm coming off a little bit of I'm detoxing a little bit today, And I feel though it's weird though now when I do have some drinks, I can feel it a few days later in like anxiety and like sadness and stuff. So it's like I had so much fun on this weekend, but now I'm feeling a little sad, but that's okay. I'll get over it. I am so excited to have Karen here today. She's an expert in women's health and in her field. And Mikkel, why don't you take a second to introduce her?
Great. Dr. Karen Desrosiers is a member of the Society of Obstetricians and Gynaecologists of Canada. She did her ObGyn specialty at Sherbrooke University in the province of Quebec. She's been working through Horizon and Vitality Health Network in Moncton, New Brunswick since 2004, as well as in a private gynecology clinic. She has a keen interest in menopause and is a board member of the Canadian Menopause Society, a member of the North American Menopause Society, and is a North American Menopause Society certified menopause practitioner. Karen is also a member of the International Menopause Society, the International Pelvic Pain Society, and the European Society of Contraception and Reproductive Health. She's currently working with BioSyent Pharmaceutical on a new treatment for PCOS. And thank you, Karen. And thank you for being part of our mission to help women become the heroes of their own health stories. Great to have you with us.
Thank you. Thank you to invite me.
Of course.
Absolutely. It's quite the resume you've got there, Karen.
Yeah. That I don't realize until you say it all that I'm busy. Why I'm busy, I guess.
Yeah. Clearly. I'm tired just reading your bio. Never mind doing all the things that you actually do. Yeah, amazing. Well, let's dig into that a little bit. Maybe you can tell us a little bit about you and a little bit about how you came to have such an impressive bio.
Oh, okay. So, as you said, I'm from Quebec. So why my beautiful accent that I can lose?
It's a gorgeous accent.
It's what my daughter said, but anyway, it's okay. So I'm from Quebec. Like you said, I got my med school in Sherbrooke as well as my ObGyn specialty. Moved in New Brunswick in 2003 with my husband that I met in med school. He's a neurosurgeon, so we're both specialists. We had 2 kids in our specialty. When I did my residency, we had 2 kids. So we moved here with 2 kids for job. To find a place for me and him to work at the same place. So we came here. I worked for 10 plus years only in the public care. And then I slowly switched and transitions to private care. Beside my work that you all say. I like to be in some public organism to help. So I did for many years until last year. I was in a association that was taking care of women who want to get out of violence. So they have a safe house for them, raising money for doing activities to raise money for them. And also, I'm still on the committee for a group that help for mental health. They help to decrease the bias and all the stigma relate to mental health, and help people who has mental health to recuperate through art, like music or painting or any kind of art. So, yeah. So I guess I'm busy.
Amazing.
That would be an understatement. Like, when do you sleep? Or do you sleep?
Try to sleep every night. No, I sleep better since I'm more in private care. I still work in public care, but not as doing calls. So having all my night to sleep instead of one of each 4 nights being on call, it's make a major difference too. But yeah, kind of it's a busy life, but
Yeah.
try to get times and have time for my kids and my family and friends also. So try to have a balance.
Yeah. So important. So important. Otherwise, it can be damaging, right?
Yep, I know too well. Yeah.
Are you comfortable talking with us a little bit about that?
Oh, I have no problem. I think it's 2015, 2014. I can remember exactly, but I had a burnout slash depressions, working 50 to 90 hours a week, having 3 kids, had school plus after school activities, and my husband was having the same kind of life.
Mm-hmm.
Yeah, and I try to be excellent in everything. It's a little of a crash in 2015, but I took a year off to recuperate and see what's next. I still love my job, so I didn't want to stop for sure. But I knew if I go back in the same regime, that I will be the same, and a second time won't be good. So um, at that time, I give up my in New Brunswick. We have practice number that you can practice alone and by yourself in a public care. So I give it up to someone else who replaced me when I was away, and I decide to do replacement of my colleague when they were going away, which they love because they come back, they don't have piles of stuff on their desk. So I did that. I did work at the French hospital. I was doing a surgery assistance, and I was working also at the family planning clinic. So I was quite busy as well, but I have the choice to take time off if I wanted. And I saw one of my friends who was opening a clinic for women's wellness. And she approached me to see if I wanted to be on their team to do gynecology in a private setting. That was in 2020 and during pandemic. And I took the challenge and I decided to go there. So now I mostly do that. And also I still work at the family planning clinic regularly. But I mostly work at the private clinic now, which I love because I realize that I like to have times to talk to patients, which is something we don't have in public care, because in public care, it's more about how many patients you can see in 1 hour beside having time to really give information. And it's, I love my colleague and they do what they can, but it's how the system is. And it's what I was doing in the past. And multitasking, mostly in OBGYN, you can have a patient in labor doing your clinic, need to go to emergency to see one of your patients. And so you pull in every ways and you don't really have time to focus on one thing and be present only for your patient. You're always your head in pull in different ways. And I think it's what gave me mostly my burnout is just, I want to do one thing at the times now.
So Karen, are most of the people that are coming into your private practice, are they perimenopausal women, or is it all kinds of women's health issues?
I have a lot of perimenopausal and menopausal women. Also a lot of cases because, when they come to see me, it's often because they're waiting for a long time to see a gynecologist or because they don't have even a GP to go talk to. So it's usually cases that are not urgent case that when you're in the public care, you cannot see, I have to see this patient in 2 months because it's possibly cancer, possibly something you need surgery rapidly. So sadly, those cases are pushed and people are affected. They're still maybe not urgent regarding like surgery or anything like that, but they have a really bad quality of life and they want to have answer. And a lot of patients just don't know what's going on. I see a lot of patients and they just say, I think I'm going crazy. I have this and that, and I'm not feeling well. Or some people I have, my bleeding is horrible. It's irregular. And they just don't know that it's perimenopause or it's menopause coming in, and they lack information about it. So they come to have this information. I see even people that saw gynecologists, but like I said, didn't have that much information about what was going on beside, it's that, take this, bye-bye. And so they were reluctant to take the medication or take the advice because they didn't really understand. So sometimes they just come to see me. And honestly, before I see them, I'm like, I don't know what I'll do. They already saw someone qualified that probably give her the right treatments. But just because I take times to explain what it is, and some of patients just want to know what's going on and they're not ready for treatments, but at least they know what is it and what can be done if they need more help.
Yeah, they know at least that they're not crazy, that they're not dying, or that, it's not something awful and horrendous. But
exactly. And sometimes they don't think that it's all connected because it's such a area of different symptoms, like physical and psychological. So sometimes they don't think that it's all related. So
what would you say? Would you say that the vulvar or the vaginal issues are the most common, or are you seeing, women coming in with, I have anxiety, depression, and they have no, they never experienced
all
before?
Of that.
Or it's all of the above?
Of that, honestly. And sometimes I always ask everything because if they're in my office, I go through all the possibilities. And sometimes they come because they have like anxiety or they have they didn't sleep well, hot flashes or anything like that. And then when I ask about vulva, so do you have any itchiness or dryness or any problem? They're like, oh yes. And then it's something that they didn't bring by themselves. But if you question that, you realize that they had an issue or pain with intercourse or anything like that. So,
right.
So you have to fish for it sometimes because people think it's normal, or sometimes they think, it's probably just a yeast infection, whatever. And they get treated multiple times. It's never worked until someone really asks and check and it's not yeast infection, it's this and that. So, sometimes you're just not informed of what is normal or not. So.
Well, and the other crazy thing about perimenopause is that so many of the symptoms could be symptoms of thyroid or
Yeah.
or a yeast infection, or it's so difficult. So how do you, when these women come into your practice, how do you even begin to figure out is it perimenopause or is it thyroid? Or
well, the first time I see her, I can have an idea it's perimenopause, but I still have to ask some blood tests because like you said, thyroid can mimic a lot of the perimenopause. I mean, it can affect your cycle, your bleeding, your mood, your energy, it can affect everything, your temperature. So yes, I need to clear out other stuff. And I explain that to patient, most probably could be perimenopause and menopause. And I explain what it is, but I said, we need to make sure it's not other hormone imbalance. But if I talk about hormone imbalance, what I find sad sometimes is I see patients who pay thousands of dollars for blood tests that are not needed, because when we treat perimenopause and menopause, the amount of blood tests that we really need to do are really limited. There's no need to do the 1,000 tests for hormone tests, because I always said to the patient, I don't treat your level of hormones. That's not the point when we do treatments. It's to make you feel better. And there's no need to pay thousands of dollars for that. So that's one of the things that I want to say to people, that you don't need to pay that much. I have another questions I have a lot is there is a test that we can do to say where am I or when I'll be menopause or if I'm menopause. And I'm like, no, there's no such test. If someone want to tell you that, it's not existing. When it is, I'll be happy. So there's no test. that can predict when or where you are. It's more the symptoms, your cycle that can help me. But it's not a thing. There's no such test.
Yeah. And the blood tests you're doing are really to rule out other things.
Exactly.
Is that correct?
It's physically for that. Yeah.
Yeah, exactly. Karen, why do you think the world knows so little about this phase of life that affects half of the population if they live long enough, and can be, I mean, some women, some individuals are lucky, they don't experience any symptoms, but what is it, up to 80% of women are symptomatic, and many of them debilitatingly so.
Yeah.
Why do you think it's such a mystery?
One thing I think we did good to teach young girls for their first period, but we did really poorly for women in perimenopause and menopause to teach them. One thing that didn't help is that WHY study came out in 2003 who blamed the hormones for breast cancer and other problems. But since that study, some people keep going and follow what happened after, because we did learn a lot from that study and learn on to refine our counseling and who to treat and not to treat. But some people just stop there, and a lot of things stop there. I mean, a lot of research stopped there, a lot of teaching stopped there. I mean, just in medical school, the amount of teaching we have on perimenopause and menopause is really limited, and after that study was even less. Even in gynae, when you do your specialty, you don't have dedicate times for perimenopause menopause clinic. You go if you have someone in the group or where you work who do menopause, but I mean, there's no rotation like a dedication on menopause. So you have the lack of information now of the new doctor. Since 2003, it's 20 years now. So of the new doctor. Some of the old one, I'm not saying everybody, but some of the old one after that study totally stopped being implicated with hormones. And having said hormones, there's a lot of treatments or a lot of intervention that can be done on patients for menopause and perimenopause that doesn't implicate hormones. So family doctor don't. In the past, family doctor were able to take care of most of the case of menopause, and the gynae was implicated for challenging cases, but now they refer most of the case. So it's one of the reasons as well why there's so many months or years sometime of delay before they can see one, because even I'll say normal case, but a case that could be resolved in the past with the family doctor, now they send a referral to the gynae, and it makes a lot of people to see. So it's getting better, and there is some talk about getting more menopause teaching in med school, and having more for patients as well on the internet. Because the problem with the internet is it's a good device, but it's easy to find crappy information. Because I search sometimes for fun, and there's some site that looks really legit and really interesting when I start, but then it's to sell products and it's just a marketing things. And then it turned out that it's a unrecognized products, super expensive. And I'm like, so we need to have something that is reliable, accurate information, and up to date.
Do you have a go-to site that you think does have some good quality information online right now?
Menopause Foundation of Canada have a really good, it's pretty new also. It's maybe 2 years max, and it's a really good device as well, good information. North American Menopause Society, which they changed their name last week, I think, to Menopause Society. So probably for now, when you search that, it will still bring you to that website. But anyway, it changed. I have a good information as well for patients. I always said to patients, if you have a website that is done by a recognized university, major university, it's usually a good website. But be careful with anything with marketing and products to sales, because good, reliable, accurate website information, they usually don't sell products. We just discuss it and we don't sell products.
That makes sense. So in addition to those resources, are there things that women can do that you would suggest that they do if they're feeling lousy, they don't understand what's going on, and they're coming in to see you or their GP? What do they do to prepare? What would you suggest they do?
when you go to doctor, I'm the same. I always forget half of my questions or half of what I want to say. So now, because I have my perimenopause brain going on, like brain fog, whatever, I write everything because I will forget. And so write your symptoms, everything, because sometimes, like I said, you don't think it's related, but it could be. So write everything, write the severity of it, like how it impacts you, how it impacts your quality of life, because sometimes we can tackle many things at the same time with treatments, but sometimes we have to decide, okay, which one is the worst for you, which one impact more your quality of life. And so it's a starting point, at least. So we go there. So, and sometimes if it's bleeding problem, you can take charts of your cycle, and there is really beautiful apps for that, for taking care of your cycle. Also, sometimes you can link some symptoms you can have on a chart, so it helps the doctor sometimes. Mostly when perimenopause, you can have like more severe PMS, so it's good to have an idea. Okay, when do you have your worst symptoms or not? If you had recent blood works or investigation, sometimes it's good to bring them. It could be useful for the doctor. If you have any questions, to write them so you won't forget to ask them if the doctor didn't answer it with the information they give you. So there is a thing that online also, I think it's linked with the Menopause Foundation of Canada, but it's MQ6. It's a questionnaire. They don't have all the symptoms of menopause, but it's a good start to see if it's worth it to go and to talk to your doctor. I mean, which is sad. Like I said, it's some doctors don't ask the questions. Sometimes they forget. Sometimes it's because they don't feel at ease to answer them and give advice, so they prefer not asking, so they don't have to answer. But I find that every doctor should ask the questions about most of the main symptoms of menopause. Like an MQ6, it's a good start. I mean, hot flashes, trouble to sleep, dryness, anything like that. And you need to ask the questions. Like I said, sometimes people get shy or think they have to suck up with that, so they don't think that it's something they should discuss with their family doctor, with the gynecologist, or they think they talk to their parents or their mom or their friends, and they say, oh, it's part of life, there's nothing to do. Or even a doctor, I have many doctors said that to their patient, oh, suck it up, it will pass.
Wow.
Which is a long period to wait, because sometimes if you count perimenopause and menopause, it could be 10 to 15 years. So it's a long period to feel crappy. So, I mean, you need to talk to someone. And like I said, if it's your family doctor or anybody, I mean, bring the subjects if they don't ask you.
Well, and I think to our experience, both Michelle and I have been very symptomatic. And our experience has been that we needed to find the information and go to our medical providers and say, no, look, we're pretty sure this is what this is, and we need help. And we've read about this type of treatment. Can we talk about this? And that's when we were able to start getting answers. But until that time, we were regularly dismissed. In fact, I had more than 2 providers say to me, well, if you're not having hot flashes and your periods aren't irregular, then you're not in perimenopause, which is not true, right?
No, but like I said, there is a lot of area of treatment. So you need someone that have a knowledge of all those treatments, which is hormonal and non-hormonal. Because one of the things we learn with the WHY, it's not black or white. Everybody is different. You have to individualize the treatments and see each patient risk and benefits. And because the best way you have a patient to follow your recommendation if they understand and agree with you. If you force something to a patient, they won't take it.
What would you say is the most common thing? Maybe Mikkelda already sort of asked this question. The most common symptom that people are coming in with?
Yeah, for sure. Hot flashes is one of those. I think that the mood things, they find that they get more angry or less patience, or
that was me,
more anxious, more depressed. And it's like I said, there is a big stigma around mental health. So a lot of the patients I was there at that time. You don't want to admit that you may have depression or depressive symptoms. And when I explained to patients that 40% of perimenopause women have depression, even if they had no history of mood disorder in the past, it's just because of the change of hormones. And I think it's one of the big one that patients like, I don't feel good, I don't have energy, and it's almost more that than hot flashes, because I think people know that hot flashes is related with perimenopause and menopause, but a lot of people don't know that mood change or brain fog or all that symptoms can be related also, or joint pain, which is something we know now that joint pain, joint stiffness is one of those. And a lot of people don't know that. So I said, oh, it's part of menopause or perimenopause, and it's like, really? So we still have a lot to teach patients about. Yeah.
For women, especially women who have not had depressive symptoms before, or anxiety, or those mood symptoms, or mental health challenges, what is the best course of treatment?
But it always depends also if the patients have other symptoms of perimenopause, menopause. When you are in the perimenopause time, we know that estrogen, the most of the study are with transdermic estrogen, with patch, but we know that estrogen will be as effective as antidepressant. And people have to understand that the symptoms can be 3 to 4 years before the actual menopause to 3 to 4 years after. You have to be careful not to stop it too early, because then when you stop it, you'll still be in depression. So you have to usually cover, sadly, a good 6 to 8 years. And I go with hormones also if they have other symptoms like hot flashes, or if they have like brain fog can have a little bit, or trouble to sleep. So someone who's already on antidepressant and got worse around perimenopause, because that happened also, if you add the estrogen, that can help also.
And I know that there's not a lot of study and research out there at this time, and hopefully that's changing as well. But I've heard, and you may disagree with this, but that the HRT can also help with some preventative things. So it could have maybe some support for your bone health, your brain health. All of those things are starting to. What do you think about?
Yeah, but the good things with people who follow the aftermath of the WHY study realize that, okay, so what we learned from that also is if you give hormone therapy to someone who has menopause for 10 plus years, who probably already have some vascular disease, because we know that when estrogen go away, it affects the blood vessels. Then you can increase heart disease and increase dementia, because a lot of dementia is vascular as well. But if you start early, the first 10 years or even before menopause itself, it can have a preventative, like a preventive for heart disease and dementia. There's a few studies that they research it now, and they said that it's possible, yes, that it can protect if you start early, compare if you start later after menopause. Yeah. So we don't give it to someone just to prevent, but if they have other conditions or other symptoms, then it can help. And then it's another benefits I see to patients, because in the news and in the media, they likes to bring up the bad, but they don't bring up the good, like it decreased colon cancer, decreased osteoporosis. They don't bring that. And it's why people need to be aware of all the other things as well, not just the bad things.
I think too, people often make the assumption that if something is natural or if it's a supplement, then it's safe, but that's not true either, right?
No, I always said to people, you have to be careful. First of all, when it's quote as a natural product, they really don't have the same research needed to approve the medication, first of all. And they have absolutely no need and no obligations to reveal or to report any adverse event. And we have a bit more retrospective study now about people who took those natural products. Like I said, it was a big marketing after WHY study. A lot of a company was like, whoa, we can have money with that. And we know now that the risks are the same. The only problem is they don't have to do a study, but also because, like I said, they don't have to report anything bad that happened with their hormones or their natural product. So natural doesn't mean good.
Yeah. Yeah. Well, I think, and even something specific like black cohosh is often touted as something that is really great for hot flashes, but that can cause liver damage, right? And I think most people don't recognize that.
But you know what? When I'm in the menopause, like I said, the Menopause Society of Canada, when they did the new guidelines, they did check all of those natural products and didn't show to be that effective at not more than placebo, honestly. And one of the problem with those natural products is we don't have long-term study of the effects. And black cohosh can have effects on the liver. So we don't know if long-term how it will damage or if it will do any problem in the liver. So the same for the dosage. Some people say, oh, it's natural, I can take as much as I want. Well, no, there's some medication that not recommended to take as much as you want. And it's a misconception that is bring on a lot by misinformation on internet. That's one of the problem. And it's not the patient's fault. It's just the way it is on the internet. You have to be careful.
What about, Karen, progesterone? I know that a lot of practitioners that focus on hormone health, if you will, often prescribe progesterone.
The progesterone, honestly, was given at some point for only reason that because it was protecting the uterus. Because at first, when they start hormone therapy, they were giving just estrogen, and they realized that it was a high rate of endometrial cancer, and they realized that you have to add progesterone. Progesterone by itself, not that useful, honestly. If you compare to estrogen, no, it's absolutely not the same range of results. The tendency now is to decrease the amount of progesterone we give as much as we can to be safe for the uterus, because there might be some implication of the progesterone with breast cancer. The rules now, it's basically to give it, but not in too much amount, like enough to control and prevent uterine cancer, but it's not the mainstay of the treatments if you want to help patients with hormones.
We're getting close to time here, so I just want to be mindful. We wanted to ask you, Karen, what's the one thing you would want every woman, in their mid to late 30s to their 50s and beyond, or maybe to their 50s, if we just focus on perimenopause? What is it that you'd want them to know about perimenopause?
Well, first of all, they don't have to suck up with all the symptoms. They don't have to have a horrible quality of life. Yes, it's part of life. Some people has it easy, some people don't. But hormones or non-hormones, we have options. If someone has contraindication to hormones, we have options. So just that they know that something can be done. They don't have to go through it feeling miserably. And there is hope. Just to tell them there is hope as well. There's a lot of work now on menopause, way more than we have in the past. There's new products that will come out for hot flashes that will be non-hormonal, that will be working really, really good. And in the future, I think we'll have more and more new products for menopause and perimenopause.
So if you're 35, this is good or maybe 30, it's perfect timing because in 5 years, we'll have all the solutions.
Yeah. And honestly, there is a good book, and I always suggest that book when I see patients it's the Menopause Manifesto by Dr. Jen Gunter. She has one for the younger one, like explaining what is menses and vaginal discharge and all that, and STI and everything. But you have another one, and it's more for the 35, 50 that explain what is perimenopause, all the symptoms. She discussed all the hormonal treatments, natural treatments, vitamins and everything. So it's really a good book if you want to get prepared for that period, because that's the best you can do is to get prepared and get informed.
Absolutely. Well said.
Amazing.
Well said. Thank you, Karen, so much for giving us your time, because we know you don't have very much of it. And thanks for all of your support. Amy, I don't know, Amy's our producer. She's sitting in the background quietly. She, I don't think she knows this, but Michelle came across Amy through a news article on the CBC. I think
Karen.
Came across Karen on a news article on the CBC. And we reached out, and despite how busy she is, she jumped in head first and said, absolutely, I'd love to be an advisor for you guys and help out. And she's been a fantastic resource. So thank you so much, Karen. It's been wonderful talking to you today.
Oh, my pleasure.
Thank you, Karen.
Wow, that was a great interview. I learned so much from Karen. Michelle, I can't believe you reached out almost like a cold call, and now Karen is not only a guest on our podcast, but also helps you out on thisisperimenopause.com.
Yeah, she's pretty amazing, especially as Mikkel pointed out, how busy she is, that she reached back and showed an interest, and she's been with us for, I guess, about a year now. She does a lot of vetting of our articles and things like that when we do something that's a bit more science-based.
And since you already know Karen, Mikkel, did you learn anything you didn't already know?
I don't know that I necessarily learned anything new, but I think what it underscored for me or really reinforced is there are solutions, and it's not big and complicated and scary. It's really just about individuals who need help finding someone who is knowledgeable and can help them sort out what's going on. I think it can seem like a very scary and daunting process to get help for perimenopausal symptoms. And it doesn't have to be. It's really, it's information is power, right?
And for me, selfishly, when we started talking down the HR rabbit hole, I have an appointment tomorrow with my OBGYN, and he's mentioned that HRT may be the solution that he's going to recommend after some test results. So I kind of wanted to, okay, so Pat, what am I asking for? Can we back up? So I may call her later. No, but so that was really fascinating for me. I was really interested in that.
Well, now you're armed with a little more information, right?
Yes, absolutely. Yeah, it was great.
Well, thank you for inviting her on. I think that myself and hopefully everyone who's listening to this learns a little bit more about it, and also does, you're right, Mikkel, feels a little more, a little less intimidated about the process and getting started and getting help.
Thanks so much for listening to the show. If you like what you hear, please take a moment to rate and subscribe to our podcast. When you do this, it helps to raise our podcast profile so more women can find us and get a little better understanding of what to expect in perimenopause.
We also read all the reviews, the good, the bad, and the ugly, to help us continuously improve our show. We would love to hear from you. You can connect with us through the podcast, on social media, or through our website. Our information, as well as links and details from our conversation today, can be found in the show notes.